In the Golden State, bureaucratic red tape and stagnant government funding are actively pushing critical community hospitals into bankruptcy.
Hmm.
And it's leaving rural communities, one emergency short of a profound crisis.
That is really the core conflict we're diving into today. This isn't just a story about small mistakes. It's a systematic breakdown.
Right.
We've collected a whole stack of financial reports, court filings, and news articles, and they all document a financial model that is so unsustainable, it's leading to the collapse of these vital institutions.
So our mission today is pretty straightforward. We want to unpack what really caused these community hospitals to fail. And many of them, they're the only emergency providers for huge geographic areas.
Exactly.
We're going to look beyond just, simple bad luck and dig into the soaring costs, the crushing debt, and the heavy hand of state and federal regulation.
And this crisis, it really hit hard right on the front page, starting back in 2023. We saw 3 major hospitals, Madera Community, Beverly Community, and Hazel Hawkins Memorial, all declare bankruptcy almost at the same time.
And Madera just shut its doors completely,
Ah.
which is devastating.
Completely. And that initial shockwave has just kept rolling. More recently, we saw the case of Oroville Hospital, or Oro Health. It serves about 50,000 residents in Northern California.
Okay.
They filed for Chapter 11 after defaulting on a huge $5 million payment. And that was part of nearly $208 million in revenue bonds.
Wow. So what's so significant about that specific default?
Well, what's crucial to understand about Oroville is that it wasn't just another hospital closing. It was the largest municipal bond default by a California rural hospital in recent memory.
So the system of public funding itself is breaking down.
It signals a really deep structural weakness. When a community relies on public bonds for its healthcare and that system collapses, something is fundamentally wrong.
And the human stakes here, they couldn't be higher. Of those 3 bankruptcies in 2023, 2 of them, Madera Community and Hazel Hawkins, were the only emergency service providers in their counties.
The only ones.
You lose those hospitals, you're creating instant medical deserts, places where minutes really, really matter.
Exactly. So we have to move beyond just treating these as isolated incidents. Are these failures just, the unavoidable consequence of inflation?
Or is there something more?
Or are they clear symptoms of systemic problems? Problems created by soaring costs that government payers just refuse to keep pace with, all layered under this inflexible regulatory regime.
Okay, so let's start there. Let's unpack this crushing economic reality. Hospitals are caught in what you can only describe as a perfect storm. They're essential services. They have to operate 24/7. But the cost of doing business is just accelerating so much faster than the money coming in.
Yeah, we've seen this intense, persistent cost inflation across the board, especially since the pandemic. The core expenses, you're talking labor, drugs, supplies, they've all gone into hyperdrive.
And labor's the big one, right?
It's huge. Take contract nurses. Hospitals relied on them heavily during staffing shortages, and their average pay more than doubled during the peak of the pandemic.
Doubled. Imagine being a hospital CFO trying to set a budget when your single biggest expense suddenly jumps 100%.
You can't. It just creates this permanent hole in the budget. And by the end of 2021, total hospital expenses per patient had already increased 11% compared to before the pandemic.
11%.
And the supply side is just as brutal. Drug expenses alone, driven by these really complex supply chains, they shot up dramatically. We're talking 36.9% per patient.
So these cost increases are hitting everyone, but the pain isn't distributed equally.
Not at all.
And that brings us to the central structural problem for these independent nonprofit hospitals like Madera and Hazel Hawkins. Their heavy, heavy reliance on government payers.
That's the key. Most of their patients are covered by either Medicare or the state's program, Medi-Cal. And this is where the system becomes financially unsustainable.
We'll break that down for us.
Time and again, the data shows that Medicare and Medi-Cal consistently reimburse hospitals for less than the actual cost of providing the services.
So they're losing money on purpose.
It's a mandatory loss. It's not a small gap either. It's an immediate, guaranteed loss on every single government-insured patient they treat.
I want to focus on the scale of that because that sounds massive.
It is. In 2020 alone, rural hospitals across the country incurred $5.8 billion in Medicare underpayments.
Billion with a B.
Billion with a B. and another $1.2 billion in Medicaid underpayments. So that's almost $7 billion in losses they somehow have to cover.
And that's not even everything, is it?
No, that figure doesn't even account for the $4.6 billion in uncompensated care, the charity care they're required to provide by law. So you're looking at a $12 billion deficit before you even talk about inflation.
That seems like a completely impossible structure. How do the big urban hospitals survive this gap if the system is designed for them to lose money?
Well, they use something called cross-subsidization. They have enough commercially insured patients, so patients with private insurance, who pay much, much higher rates.
Oh, right.
And those high commercial rates generate the profits they need to offset the massive losses from treating Medicare and medical patients.
But the rural and independent hospitals, the very ones we're talking about, they don't have that volume of commercial patients.
Precisely. They're often treating older, sicker, and poorer populations who rely almost entirely on those underpaying government programs. They lack the high-paying commercial base to fill that $7 billion hole.
And that leads directly to the kind of cash flow crisis that forces them into bankruptcy.
Instantly.
You look at Beverly Community Hospital, the sources show they were losing approximately $5 million a month.
$5 million a month.
They projected they would be completely out of cash by September 2023. I mean, that's the definition of bleeding out.
And even after filing for bankruptcy protection, the situation is still dire. Hazel Hawkins Memorial, they expected to completely exhaust their cash reserves by November of 2024.
So when the primary payer, the government, is setting rates that starve the institution, there's no way out.
They can't invest, they can't maintain their own infrastructure, and eventually the doors just have to close.
Let's pivot now, because beyond that basic financial deficit, we need to talk about how administrative complexity and legal penalties drain the capital these hospitals so desperately need.
Yes.
And the story of Oroville Hospital seems to perfectly illustrate how bureaucracy can actively sabotage a hospital's recovery plan.
The Oroville case is a masterclass in regulatory entanglement. They were already financially weak long before that bond default. The hospital had to agree to a massive $10.25 million settlement.
$10 million.
With state and federal governments, and this was to resolve allegations about improper coding and kickbacks that went all the way back to 2014.
That is a colossal sum for a rural hospital. They're being forced to cough up tens of millions of dollars at the exact same time they need to be saving cash for a huge expansion.
And it wasn't just the government. They were also hit with a separate $16.8 million lawsuit from a construction contractor over unpaid invoices.
All related to that new building.
You see how quickly the capital just dries up, but the most absurd and financially crippling detail, it involves the municipal bonds they issued.
Right, the $196 million.
Exactly. Oroville borrowed nearly $196 million in 2019 to fund that expansion, including a state-of-the-art $96 million patient tower. That debt was all contingent on the revenue that new tower was supposed to generate.
And that tower was completed. It was physically ready to accept patients, but the doors stayed shut.
For 9 months, a fully built $96 million asset remained locked and unused because of, and I'm quoting here, regulatory approval delays.
Wait. So the building was done, the equipment was in, but the government just wouldn't give them the final green light.
That's right. The infrastructure was there, but they couldn't operate it to earn revenue.
That's truly unbelievable. The debt clock is ticking. They owe millions in interest payments every single quarter, but the bureaucracy has their cash register locked.
You can't service $196 million in debt if your key revenue generator is sitting empty for almost an entire year. It perfectly illustrates the fatal flaw. We're talking about $3 to $5 million in annual debt service they just couldn't pay.
It's like a business taking out a huge loan to buy a machine, but the state holds the operating permit for 9 months.
Yeah, and it forces the company into insolvency because they can't run the machine to pay back the loan. The regulation, which was intended to ensure safety, instead created a catastrophic financial failure.
And this paralysis, it wasn't just confined to one tower. When Madera Community Hospital collapsed, policymakers were apparently shocked by the data lag the state was operating under.
Oh, yeah.
The most recent financial balance sheet data the state had on hand was often 18 to 19 months old.
Think about that. The state agency responsible for monitoring hospital health, HCAI, was looking at data that was almost 2 years out of date.
So they had no way of knowing a hospital was in trouble.
They had no mechanism to identify distress or to intervene proactively until a hospital was already completely bankrupt and turning away ambulances.
They were forced to pass emergency regulations, this Assembly Bill 112, just to mandate quarterly reporting.
It just underscores how deeply reactive and, frankly, how irrelevant the government oversight had become. They were operating almost 2 years behind reality, while these hospitals were losing $5 million a month.
So the systemic failure is clear. An unsustainable financial model from inadequate government reimbursement, magnified by legal penalties, and crippled by bureaucratic delays that just freeze capital.
Right. So the question becomes, when the crisis finally hits, what kind of lifeline actually works? Is it more government debt, or is it the stability offered by the private sector?
Yeah, let's look at the state's response first. They recognize the severity of the crisis, so they set up the $300 million Distressed Hospital Loan Program, or DHLP.
Offering interest-free loans repayable over 6 years. This is taxpayer-backed debt, basically, designed to keep the doors open.
And the need was immediate. Those 3 bankrupt hospitals from 2023, they alone applied for $125 million from that fund.
And Madera, which needed to completely restart its operations from scratch, requested $80 million. They noted, quite rightly, that reopening a closed facility is very expensive.
So this state solution, while it might be necessary in the short term, it's really just shifting debt around, isn't it?
It is. It doesn't fix the underlying structural problems, the rate gap, the regulatory delays. It just moves the financial obligation from the hospital's balance sheet over to the taxpayer's ledger.
And just hopes things get better in 6 years.
Exactly. Now, contrast that approach with what we're seeing from private healthcare chains. They aren't just shifting debt. They're injecting management expertise and the capital resources needed for long-term viability.
This is the market providing the operational stability that these independent nonprofits lacked.
Yes, we're seeing Adventist Health, which is the 7th largest system in California, stepping in as a proposed manager or buyer for both Madera and Beverly.
And Adventist has a track record here, right? They've done this before.
They have. They successfully revived the Tulare Regional Medical Center about 5 years ago, and they bring the necessary scale. Their terms for reopening Madera required at least $55 million just for the first year alone.
$55 million.
For what? Just to cover essential staffing, supplies, and maintenance? They can provide that capital, and more importantly, they can leverage centralized purchasing and standardization across dozens of facilities.
Which means they can negotiate better prices for all those soaring drug and supply costs we talked about earlier.
A negotiating power the small, independent hospitals simply never had. They're fixing the operational inefficiency that's inherent in that small, standalone model.
Right. Their bid for Beverly Community Hospital was explicitly called the greatest chance for that facility to keep serving its community.
And that came after a rival deal fell apart because the bondholders were nervous about the financial stability of the other company. When you're facing financial ruin, a capital injection from a stable, large-scale operator is often the only realistic path forward.
And even Hazel Hawkins, which is a public district hospital, is pursuing a lease-to-own partnership with a private, for-profit company.
American Advanced Management. They specialize in taking over distressed rural hospitals. Now, this deal requires local voter approval, but it speaks volumes that a public district is turning to private expertise to ensure its own survival.
It shows that these private systems are stepping forward with the resources and the specialized management that's required to make these non-viable facilities financially functional again.
It really highlights that in high-cost, high-regulation environments like California, sheer size and operational efficiency are crucial survival tools that these nonprofit districts often just can't match.
So let's synthesize what we've uncovered for you. You now understand that California's hospital crisis is not just random bad luck. It stems from a fundamentally unstable financial model.
A model where government reimbursement fails to cover soaring costs, and that instability is then magnified by punishing legal penalties and these bureaucratic delays that actively freeze capital.
We've seen that rural hospitals are uniquely vulnerable. They're overloaded with patients on underpaying government insurance, and they can't offset their losses with high commercial rates like the big city hospitals can.
And when these public systems strain to the point of collapse, it's often large, private health systems that step in to inject the necessary capital and operational stability, and in doing so, they preserve essential services for the community.
We spent some time detailing how those regulatory delays kept Oroville Hospital's brand new $96 million patient tower locked and unused for 9 critical months, collapsing the hospital.
And how the state's own oversight was operating on data that was nearly 2 years old.
This all raises a crucial structural question we have to consider. In critical infrastructure like healthcare, does the impulse to regulate and fund institutions exclusively through bureaucracy, with its inherent data lags and payment gaps, sometimes end up creating the very access crisis it was designed to prevent?
That's something to keep in mind as we watch the future of California's critical care unfold.